Hello, let's discuss this question. A 29-year-old woman comes to the office due to worsening pain in her right knee. The patient has had increasing knee pain and swelling for the last 3 months, which has prevented her from going to her yoga class and running on the weekend. She has tried taking ibuprofen, okay, which is NSAID, and putting ice on her knee, but these interventions have provided little relief. Okay, the patient has no chronic medical condition and does not use tobacco, alcohol, or illicit drugs. Temperature is 37.2 degrees C. On examination, the right knee has mild soft tissue swelling with no effusion and with decreased range of motion. Okay, so soft tissue swelling and decreased range of motion. X-ray shows an expansile lytic lesion at the epiphysis of the distal femur as shown in the exhibit. Complete blood count and serum chemistries are normal. Which of the following is most likely diagnosis? Okay, so first we have to look at the X-ray. So the X-ray show the lytic lesions. X-ray shows the lytic lesions. Okay, the lytic lesions on the distal femur epiphysis of the distal femur. So you can see the lytic lesions. Okay, these are the lytic lesion on the distal femur epiphysis. Now what will be the diagnosis? Okay, so the diagnosis in this case is the woman is in a young adult. Okay, young adult, and she has worsening pain, and there is lytic lesion at the epiphysis of the distal femur, so it is most likely giant cell tumor, because giant cell tumor causes the lytic lesions, which is also known as soap bubble appearance on the epiphysis of the long bones. Okay, so the giant cell tumor, why it is not the Baker cyst or Osgood's skeletal disease, osteitis fibrosa, cystica, osteoarthritis, and osteoid osteoma. So look at those options. Okay, so this is a giant cell tumor. Okay, giant cell tumor of the bone, which is the benign tumor. Okay, benign tumor, and it causes the lytic lesions, which are called soap bubble appearance. Okay, on the epiphysis of the bones. So the giant cell tumor, about the patient, first this we look at this. The patient has progressive knee pain with lytic bone lesion consistent with giant cell tumor of the bone. Giant cell tumor of the bone is a benign but locally destructive neoplasm that is most uh, common at the epiphysis of the long bones. The incidence is highest in young adults who have reached skeletal maturity, but can also occur in older adults, typically associated with Paget disease of the bone. The course is variable. Most patients have only local manifestation like pain, swelling, stiffness, pathological fracture, but pulmonary mets and malignant transformation may occur. X-ray in giant cell tumor of the bone characteristically shows an eccentric lytic lesion, which is often described as resembling soap bubbles. CT imaging can show the greater detail of the mass, and MRI is often indicated to visualize the adjacent soft tissues. The diagnosis is confirmed with biopsy, which shows multinucleated giant cells resembling osteoclast interspersed with sheets of mononuclear stromal cells. Surgery is the first line treatment, and it will include the intralesional curettage or excision. Monoclonal antibodies like denosumab against the receptor activator of nuclear factor kappa B ligand, rank L, which is overexpressed in the stromal cells, can also be used to shrink the tumor. The other option, like Baker cyst, which is also called popliteal cyst, it is caused by extrusion of the fluid from the knee joint into semimembranosus or gastrocnemius bursa. It is typically seen in patients with underlying knee disorders like osteoarthritis and present as an asymptomatic bulge in the popliteal fossa or pain and swelling in the posterior calf. X-ray findings on osteoarthritis include joint space narrowing, subchondral sclerosis, and osteophyte formation, but the epiphyseal bone is normal. The young patient with no history of joint disease is unlikely to have osteoarthritis or Baker cyst. Okay. Then the other option, which is Osgood Schlatter disease, also known as TBL tubercle apophysitis. It causes pain at the insertion of the patellar tendon. It usually occurs in the adolescents or pre-adolescents patient and frequently follows a rapid growth spurt. X-ray may show avulsion of the tubercle, but the femur is normal. Then the other option, which is of the osteitis fibrosa cystica. Okay, so in patient with advanced hyperparathyroidism, this condition occur. They can develop increased resorption in cortical bone with subperiosteal thinning and cystic degeneration, which is called osteitis fibrosa cystica. Although X-ray may show lytic lesions, most patients have multifocal involvement and either symptoms of hypercalcemia like constipation, fatigue, in primary hyperparathyroidism, or a history of chronic renal failure in secondary hyperparathyroidism. The other option was osteoid osteoma. It is also not correct because it is the benign bone tumor that appears on imaging as a small round lucency. It typically causes nocturnal pain that is quickly relieved by non-steroidal anti-inflammatory medication like ibuprofen. And this patient has taken ibuprofen, but the pain is not relieved. So the most um likely option is giant cell tumor of the bone. Giant cell tumor of the bone is a benign but but locally destructive lesion that is common at the epiphysis of the long bones in young adults. Most patients have local manifestation like pain and swelling, but pulmonary mets and malignant transformation may occur. X-ray shows an eccentric lytic lesion often resembling soap bubbles. The diagnosis is confirmed with biopsy and surgery is the first line treatment.